Hello.
Hello, everyone. Sorry about that. Hi, welcome tonight for the HT-Vista webinar. So thank you for joining us tonight. You have Dr. Gillian Dank, who is based down in Israel. You've got Lyron, who is also a fellow vet colleague, who is based here in London. I can see people are joining at the moment, which is fantastic. What I'm going to first do is just do a poll, which will buy us a bit of time whilst people are getting their computers working and signing up. And hopefully this will also help Gillian and Lyron in today in directing us a little bit on some of the background of some of the audience who are listening. So I'm just going to launch this, and if you can fill in the details, that would be great. So we'll do this for a couple of minutes whilst we're waiting for people to sign up. So thank you those who arrived early, and hopefully this will help.
Thank you, Stephen. Can you make me the host, please, as well?
I have. You're already a panelist.
I cannot share my screen.
That's why you're able to do things. But I just need to go and whilst that is going, nope, that's not what I wanted to do. Sorry, just 1 second. You should be able to share stuff as a panelist now.
Let me try again. Nope.
Let me just try this 1 second. So both of you should be able to do that now.
Yeah, perfect. Thank you.
All right. All right. Welcome, you two. Nice to see you.
And you. Thank you, everyone, for coming, for joining us.
So we will just wait a few minutes whilst people are filling that in. But what would be good at this point for those of you who do not know Gillian and Lyron, I'll let Lyron explain who he is and how it all plays a part in this. And then I'll let Gillian go and do an introduction of herself as well. And then hopefully we'll have filled in all of the polls and everyone hopefully will have joined us who is meant to be joining us today. I think we had over 100 people sign up, so it's a good number of people. Yeah.
Brilliant. Can I just double check that you are seeing my presentation and you can hear me? Perfect. So yeah, thank you, Stephen. I'm Liron. As Stephen mentioned, I'm a vet. Gillian was my mentor when I was a vet student back in Israel when I did my internship as well. And then I moved to the UK, practiced in the UK, mainly emergency and critical care. So I've kind of seen as probably some of you have seen the kind of end kind of side of these cases when they come to us when it's a bit too late. So now I've moved to the more of the preventative side of medicine and focusing obviously on trying to save lives through the technology that we are going to present to you today. And I am currently the managing director for HT-Vista, so overseeing a company globally, so the US, Europe, UK, and a little bit of Australia as well. So that is me, and I'll let Gillian introduce herself as well.
So hi, everybody. Good evening, good night. My name is Gillian. I went to vet school in Israel, and then I went to the University of Davis in California for my residency in oncology. And I'm boarded in at ACBIM and ECBIM. After I finished my residency, I came back to Israel, and I was the entire faculty of oncology at the Koret School of Veterinary Medicine at Hebrew University for 20 years. And 2 years ago, I left the university and went into private practice. And I've been a consultant, and I'm now working with the company as the chief veterinary officer for a couple of years. And I think this is a great device. So we're here to talk about it.
That's great. You do at the bottom, and someone's already used it, use the Q&As. There's also a chat room as well. And we will endeavor to try and answer questions, although I can't help you in regards of your noisy baby. So I apologize for that, Christina, but we can't hear it, so you're doing very well. What I'm going to look at now is just the poll, and then we'll kick off. And thank you for attending tonight's lecture, which is a joint collaboration between VBS Direct and HT-Vista. So if I look at the poll, the first question was, do you presently screen all cancer skin cases in your practice? And 71% say yes. So you've got a very educated and proactive group here tonight. 29% said no. That doesn't mean you're bad. It just means hopefully tonight will give you an option of becoming even more proactive in what you're doing in your practice. If yes, what do you do? 93% do needle biopsy. 36% do a full skin biopsy. 36% do a in-house slide test. Another 50% send them off to pathology. And then others use 7% use screening technology, which may be HT-Vista, because I didn't go and state that. So it could be, you may already have some enlightened souls. So of the remaining question, what limits your cancer screening skin in practice? The unreliability of equipment is 21%. The lack of training is 14%. The variability between patients in clinical results, 36%, which I think you're going to touch on tonight anyway, Gillian, so that's very apt. And then the easier to remove surgically than biopsy, 21%. Difficult to market to pet owners, 7%. Owners not keen on having needle biopsies, 36%. And again, I think HT-Vista will help a lot in that, convincing those individuals. Cost of pathological lab results. Again, I think HT-Vista, you'll hear from tonight, will go and help you in convincing clients of the necessity to go and do a pathological test. And then multiple growths in the cost. Again, I think HT-Vista will help on that. And other reasons is only 7%. But if anyone wants to put in the chat room what the other reasons are, I'd be very interested, except screaming babies, which doesn't count. Okay. Thank you, Gillian. Thank you, Lyra, and thank you everyone for participating. And now I will shut up and let the professionals carry on.
Lovely, thank you very much. So I'll just give you a bit of a kind of roadmap of what we're going to do today, so you know what to expect. Gillian will do most of the talking. You'll be happy to hear that. And Gillian will be speaking about canine soft tissue sarcoma. And as Stephen mentioned, because we are introducing a new technology and a new screening way of screening those lumps and bumps and potentially assisting you in getting those lumps diagnosed in your clinic, I thought I would give you a bit of background. I see that maybe there are some individuals that have the HT-Vista device already in their clinic, so this is really nice to see, and thank you for joining us. So what I'll do a quick background, explain about the technology, show you a few things that are happening behind the scene as well, just to kind of explain about the technology a bit better. And then I'll hand over to Gillian, who will share with you some very interesting cases about soft tissue sarcoma, and more specifically how to get them diagnosed, so we can really get those cases treated earlier and improve the prognosis and the outcome for the patients. So that's what we're talking about, right? So I'm sorry about some of the graphic images, but I'm sure you obviously are used to it. So we're talking about lumps and bumps in dogs. And as you know, they are very common, and hopefully you would agree that you see them probably on a daily basis. What we also know that an average clinic would see them at around kind of 500 to 600 kind of those cases a year. And it's a very, very common problem. And as some of you, and I've looked at the percentages, really kind of encouraging to see, we'll agree that diagnosing them based on palpation alone is not best medicine. And we know that basing our diagnosis on palpation alone put us at risk, put the patient at risk, and we do want the best for the patients. And we want to give those pet owners as well the best advice, because they come to us and they are looking for the right advice from us. So hopefully everyone agrees this is something that we can all agree on, that diagnosis cannot be done on palpation alone. What I also wanted to share with you is some statistics that we have gathered from our own database. So as I don't know if you know, but we've scanned thousands of masses in the last couple of years, and about well, I think a couple of thousands of those masses have been validated by a cytology or histopathology by the practices that have been using the device. So what we have done, we've kind of gone into the data and we have mapped those masses based on the location. And what I'm showing you is now the split between benign and malignant tissues per location. And you will see that, you know, it might be that you might kind of be able to make a calculated guess. Obviously, some are contributing to the risk factors that Gillian potentially will discuss later. But what you also can see, what you can gather for that is that there is no one location that is 100% chance for one of the or the other. And the same for the breeds. So we went and looked into the breeds that have been included in the validation part of the database. And we have seen that maybe there are some breeds that are more prone to have more benign or malignant tissues when it comes to lumps and bumps. However, again, there is no 100% chance for one breed to have one or the other. So I think at this point, I think we all agree there are some risk factors, there are some evidence that might kind of help you make a calculated guess. We cannot base our decision on palpation alone, and that's why we need to further investigate. Unfortunately, as some of you have mentioned, our decision or our advice is not always being accepted by owners, and some of them might decline due to different reasons. If it's cost, if it's there is the age of the patient. We know that some of them or most of them are over the age of 10, so the owner might not want to put them through any unnecessary anesthesia or sedation. So really kind of a few kind of reasons why owners potentially would decline those or this advice from you guys to further diagnose. So what we need is a screening tool. We need a screening tool that allows us to screen out those benign tissues, to kind of have very high confidence and a reliable test to tell us that we can quite easily rule out those masses and say that they are benign, or let us know when those are cases that are slightly suspicious, where we need to further investigate, and those cases we need to focus on. And that's why we wanted, obviously, to show you the HT-Vista device, which is included in some of the or all of the cases that Gillian will present later. So this is the HT-Vista. It's a tablet, basically, with a probe that is linked to it at the back. And there is obviously a software that we developed that is allowing you to scan those patients. So the HT-Vista, as some of you will know, is the first non-invasive AI-driven screening tool. And it really allows those, you guys, the clinicians, vets, nurses, technicians, to rule out cancer of dermal and subcutaneous masses on the spot in your own clinic. And because it's AI-driven, it's because it's the data is being analyzed on the spot, you get the results very quickly. The patient is present, the owner is present, and you can then make a calculated decision with the owner what further investigation, if at all, needed. And this is Dr. Gillian Dank, and just to show you the size of the probe, so this is how we scan patients, and this is the tablet that obviously holds the software as well. So just a little bit about the technology, so you are a bit more familiar with what's happening behind the scene. The technology that the HT-Vista uses is called heat diffusion imaging, and it's based on the fact that benign and malignant tissues behave differently when they are exposed to heat. So when a tissue is exposed to heat, if it's a benign or malignant tissue, it shows different thermophysical activities, so different thermophysical features that differentiate between malignant and benign tissues. So what is happening, basically, that the tissue is being heated for 10 seconds by those two heat sources. And then the tissue is allowed to cool down naturally for 30 seconds. So all in all, it's a 40-second scan only. And throughout the 40-second scan, there is a thermal camera and sensors within the camera that pick up all the thermophysical activities within the tissue and record this activity. In fact, what happens, and this is the next video that I want to show you, what happens, the device throughout the 40-second scan collects 640 frames, thermal frames of the tissue as the tissue hits and gets heated and as the tissue cools down. So I'll show you a quick video how it looks like. So this is the tissue when it gets heated. And you can see the obviously red, orange colors are hot, and then it's left to cool down. And what you're seeing here actually is a healthy tissue on the right-hand side and the mast cell tumor on the left-hand side. So you can see that there are different features. Obviously, we cannot interpret those features and the differences, and that's why we have developed the algorithm that we have currently, that they're using currently to help us analyze this data. So all in all, what happens? You need to click quickly the area of interest. You scan the area for 40 seconds. There is a quick step which I can show you. I'll show you in a second how it looks like to mark the tissue to the device, and then the analysis happens within 2 minutes. So all in all, 4 or 5 minutes, you get the procedure done, but also get the results done. So I just want to quickly show you how it looks like. So basically, what you will see, this is how the app looks on the screen of the device. And I'm starting the scan from the moment we pick up the device, when the device is ready, and you can see that I will pick up the device now and place it on the mass. Okay, so we place the device on the mass. And once the mass is in the right location, sorry, apologies for that. Once the mass is in the right location, then the scan starts. So the scan starts by pressing the start button. And then once the scan starts, again, the tissue gets heated and left to cool down for 40 seconds. Once the scan is finished, then there is a quick short period where we mark the suspicious area to the device whilst leaving enough healthy tissue for the device to use as a reference. And by using this reference, the device now will know what happens, what kind of thermophysical activity is happening within the tissue itself, the mass itself, and it will allow us to, it will allow itself actually to interpret and classify this mass to the point that it will be able to tell us whether it's a benign tissue at a high level of confidence, or if further investigation is required. So we are marking the tissue itself, and then we are leaving a little bit of buffer area of an area that we are not quite sure about, which will happen now. So this is the buffer area. And then the last bit is we ask the device to analyze the data. And you can see that then there is healthy area, which is used as a reference. And then it will allow us to know what is happening within this area, and whether this area is benign or requires further investigation. So again, the report gets to the user very quickly. And on the report, what you see is a score within a scale between 1 and 10. Any score between 5 and 10 we consider to be benign at a high level of confidence. So the device, you will see in a moment, the device sensitivity is 90%, and each score that you get from the device represents the probability of the mass being benign. So this is the specific negative predicted value for each scan. So for example, this mass got 97%, 9, which represents 97% chance of the tissue being benign. As you can see, as if the mass goes through many tests, and as it starts failing those tests, the probability declines until it gets to the point where we are unable to say in a high level of confidence this tissue is benign, and therefore once it drops below 90% negative predicted value, we highly recommend actually to further investigate by sampling the tissue and offering more invasive procedures. So just before I finish and I hand over to Gillian, we have done a few studies which were published last year, all of which obviously been overseen and done by Dr. Gillian Dank. The first study, the first pilot study, was done in a referral center on a small volume of cases and achieved a sensitivity of 90% and a negative predicted value of 95%. Based on that study, we've continued and performed another study, which is the training and validation study. That was done in a GP setting with many more cases, so about 664 cases, so much more volume of cases. And this study has achieved a sensitivity of 85% and negative predicted value of 98%. However, since this is an AI-driven tool, and we work with practices across the world that continue to add more data to our database, and we continue by using this data, we continue to educate and teach the algorithm more features, and when it's right or wrong, we have now managed to achieve a performance of the current algorithm that is running in the cloud of 90% sensitivity and a negative predicted value of 98%, an average negative predicted value of 98%. And hopefully you would agree that this is a great result for a screening tool, and this is exactly what we want from a screening tool, to really allow us to capture all those positives, and when the device tells us this is negative, we want to rely on it and have a reliable tool that we can trust when we are in clinic. So this is the device and this is how it works. And what I'll do now, I'll hand over to Gillian, who will share with us some of her cases and show you how it is important to diagnose those cases.
Thank you so much, Liron. So we're going to talk about a couple of real cases that I've seen over the last month that I think can kind of show you why HT-Vista can really help us, and so we can also learn a little bit more about soft tissue sarcomas, which are, I think, a tumor that everybody sees all of the time. So this is a very interesting case. This dog's name is Sivan. She's 6 years old. She's a female spayed, and she's lived with the owners since she was 6 months old. And she lives, obviously these cases are all from Israel, and she came from Germany, and she lives indoors. And these owners love this dog. A little bit more than a year ago, she had a sarcoma on her right front leg, and they went for surgery, and the tumor was removed. The tumor removal was very successful. However, the surgery was not successful, and they did a flap that didn't work and didn't close, and then they did another flap, and she gradually healed, and the owners were very happy about how she was doing. And then all of a sudden, 2 weeks ago, she went for a haircut, and they felt a couple of bumps, which was very unusual, and they were very worried about that, and they went right to the referring veterinarian. They did a fine needle aspirate, and he said it was histiocytic. And the owners said, well, that sounded weird because she had had a sarcoma in the past. Why does she now have a histiocytic tumor? And they decided to perform a biopsy for a definitive diagnosis. Now, to be honest, just based on this case, obviously, as I'm sure you know, it would be very unusual for a soft tissue sarcoma, which is supposed to be a locally aggressive tumor, to come back as multiple nodules all over the dog. And histiocytic would actually make more sense, but the owners decided to do a biopsy because they were very worried about their dog. So this is the answer from the biopsy. The tumor was in the subcutaneous, was expanded by densely cellular, unencapsulated, well-demarcated, well-differentiated spindle cells. So indeed, this was not a histiocytic sarcoma. This was a soft tissue sarcoma, grade 2. Does it have anything to do with the tumor from a couple years ago? We don't know. At this point in time, we only saw about 3 or 4 tumors because the dog was a little difficult. And we really weren't sure about what we wanted to do. And so we thought we'd try to check her out and see what was going on. The more we checked her, the more masses we found. We found over 20 masses on this dog. As you can see, they all ranged between 0.5 and 2 centimeters all over her body. The more we checked, the more we found. Obviously, I'm sure that you all know that even if a dog has 5 masses, 3 masses, 20 masses, it doesn't necessarily mean that they're all the same tumor. We can obviously, I've seen dogs that have had 10 masses, that have had 3 lipomas, 1 melanoma, and 2 mast cell tumors. So the fact that we have multiple masses on a dog doesn't necessarily mean that they're all from the same origin. Next slide. Okay, so in her case, we decided to check the masses with the HT-Vista. Again, thinking that maybe 1 or 2 could have been sarcomas that were biopsied before she got to me, but what are the chances that they're all sarcomas? And unfortunately, they came out as most likely being suspicious. So we continued to work her up. So again, multiple masses do not necessarily mean that everything has the same cell or of origin. So in her case, we checked multiple masses. Every mass that we checked came out orange, which means that it needs to be further investigated. And in her case, we decided to follow up with an aspirate. And here you can see the aspirate. So as I'm sure you know, anytime we're aspirating tissue, we can have a few different cells that come out. First of all, we want to understand whether the sample is cellular or not cellular. And if it's cellular, we want to try to understand whether it's inflammation, infection, or tumor. If it's inflammation and infection, we'd expect to see neutrophils, macrophages, and cells like that. If it's tumor, we want to try to differentiate whether it's round cells, whether it's carcinoma, or whether it's a sarcoma. In this case, as I'm sure you can all see, this is definitely a sarcoma. In sarcomas, we see spindly cells, which you can see here on the right. The cells are very large with multiple nucleoli and very spindly. And this is most definitely diagnostic for a spindle cell sarcoma. And here you can see it even better. So what are we going to do with her? So the owners, as I'm sure you already understood, wanted to do absolutely everything. So, I mean, if she had only had 3 or 4 or 5 masses, we certainly could have said to them, let's wait a week or 2. If in a week or 2, there are still only 3 or 4 or 5 masses, we can surgically remove them all. However, as we understood, as we were continuing to do her physical, the more we looked, the more we found. And no, I do not think that it's reasonable to do surgery on a dog with over 20 masses, because the way that they were growing, we probably do surgery on this dog, remove all 20 masses, and then they probably come back a week later and have 20 more. So in her specific case, only if there had been under 10 masses, I could have possibly recommended surgery. The other option would be metronomic chemotherapy. There are certainly very good articles in veterinary medicine discussing metronomic chemotherapy for soft tissue sarcomas. So if some of you are not familiar with it, metronomic chemotherapy is low doses of chemotherapy. And the purpose of that treatment is to try to work on the anti-angiogenesis of the chemotherapy and of the tumors, and prevent them from growing. So that's the treatment for that is a combination of either cyclophosphamide or chlorambucil with an NSAID, so it has less of a chance of toxicity and may slow down the process. And obviously the other option is to do nothing. So most sarcomas, unlike the case that I just showed you, are in older dogs and cats and are solitary. So that case was a real zebra. The etiology, sarcomas have been associated with radiation, trauma, foreign bodies, and parasites. And in dogs, it tends to be overreported in larger breeds, especially in flat-coated retrievers. They develop from mesenchymal tissues, as you all know, and this family of tumors does not include hematopoietic tumors or tumors of lymphoid origin. Often we discuss them as a family because they have similar clinical behavior and similar histological features. So what makes them special? The features that make them special, the first thing is that they tend to appear pseudo-capsulated and firm. So when feeling them, you think that you know where they are. You think you can go into surgery and remove the entire tumor, but you actually can't because it's not a capsule, it's a pseudocapsule. So they actually have poorly defined histologic margins, even though it feels like you can get it all out. So you can see on the picture of the dog that you can see that you have the tumor that you think you can get out, which is the green part, but it's actually getting much further out. And if you just remove the small tumor, you're actually leaving all of these tentacles. So some people talk about soft tissue sarcomas as if they're a tree with roots. And if you only take out the top part of the tree, you're leaving all these roots, and it's just a matter of time until they grow. Some people use the octopus example, that you're leaving all the tentacles. So you need to get the entire tumor with margins, otherwise it's just a matter of time for it to come back. And that's why these tumors have to be imaged to understand where they are and how far they're getting into the tissue. So obviously a local recurrence after conservative surgery is common because you're not getting it all out. The metastasis for this group of tumors is through the blood in up to 20% of the cases, usually not through lymph nodes. The only cases where lymph nodes can happen are in synovial cell sarcomas. The most important thing for prognosis is histologic grade. So anytime you're removing soft tissue sarcomas, you need to make sure that your pathologist is giving you the grade. And resected tumor margins will predict the local recurrence. So if you get really good margins, it most likely will not come back. In addition, they have poor response to both chemotherapy and radiation therapy when they have measurable or bulky diseases. So there have been several articles discussing giving chemotherapy and radiation because you can't do surgery on them, but it's much better to try to do surgery and then follow up with either chemo or radiation. So this is another dog named Maple, 10-year-old mixed breed indoor dog. Last year there was a mass on her elbow, and on aspirate it was a mesenchymal tumor. It grew gradually over time, doesn't bother her. She's not lame. It's on her left front leg, 4 by 3 centimeters, subcutaneous and circumscribed. But there was also another mass on the sternum, 4 by 4, subcutaneous, circumscribed, and that had been aspirated as a lipoma. So she has 2 different masses with 2 different diagnoses. So we weren't really sure about the aspirate that had been done a while ago. So we wanted to make sure that it wasn't just 2 lipomas and we weren't just going to do a workup for nothing. So we did the HT-Vista. Here again, you can see that we're in the orange area, that there is a chance that this might be a malignant tumor. And the probability is that we should continue, the benign probability is 73%, indicating that we need to continue our workup. So here again, my recommendation in any case, when we're talking about cases that need to be worked up, that we do an aspirate, that we don't go straight to biopsies, that we do an aspirate, because there will be some cases of inflammation and infection that may come out positive. So we don't want to just do surgery. The differentials in this case obviously could be for any kind of subcutaneous tumor, could be round cell tumors, either mast cell tumors or histiocytic sarcomas, hemangioparasitomas, fibrosarcomas, hemangiosarcomas, osteosarcomas, chondrosarcomas, and squamous cell carcinomas. When looking at this list a little more closely, what you can see is that some of these tumors on the list cause lameness and some do not. So if we have a dog like Maple, the chances of having an osteosarcoma or chondrosarcoma when she has no lameness are very, very unlikely. And on the other hand, the chances if another dog came in with lameness, the chances of him having either a mast cell tumor or hemangioparasitoma are very, very small because they do not cause lameness. So we want to look at our differential list, look at the dog and see which are most appropriate. So again, fine needle aspirate, and here on the fine needle aspirate, we actually did see cells, and again, can diagnose. So we really need to do these fine needle aspirates to rule out lipomas, seromas, inflammation, and abscesses. There certainly may be cases when we do a fine needle aspirate and we have no cells on the smear because they're not exfoliating. But the other problem is that sometimes if you have some scar tissue, then the mesenchymal cells will come from scar tissue the same way that they come from malignant tumors, so that could actually mix you up. If you have a big, very large tumor and with a lot of necrosis, then you can do an aspirate and get necrotic tissue and get a false negative, which actually happened to me last week, which was very, very, very annoying. So obviously fine needle aspirates are not 100%, but certainly in cases when you get a positive answer, that's the first thing you want to do. Another important thing is that if you have a case where you do fine needle aspirate and then you look out on your smear and you see nothing, it also could be a lipoma, because obviously when you look at lipomas that have been that you send for cytology, there's nothing on them. And that's very important, that when you're doing smears of lipomas, that you want to write down, okay, I saw fat, because then when that fat disappears, you know that it was indeed a lipoma and not just a sarcoma that didn't exfoliate well. Okay, so what do we want to do in her case? Obviously, the most important thing to do in any case when we suspect that there's a sarcoma is imaging. And the best imaging that we can do is a CT. So this is a CT. We do a CT of the mass and the thorax because we want to know that there's no evidence of metastasis to the lungs. And this is her mass on CT. You can actually see that it's not on this view. On the previous view, it wasn't that easy to see where this mass starts. It wasn't that circumscribed. But on the next view, you can actually see much better exactly where the mass is. And based on that, the radiologist and the surgeon actually did say that this is surgically resectable. So here you can see it was an oval subcutaneous soft tissue mass, 1.7 on 4.3 centimeters, and no evidence of osseous involvement. And the third case that I wanted to share with you today is as of this dog, Bamel, a 12.5-year-old, 35-kilogram mixed breed dog that presented to the referring vet with swelling of the carpus. Yesterday, he was a bit lame on that leg. So what are our differentials and what is our problem list? So obviously the problem list is this mass on the distal radius, carpus. And our problem list is very similar to the problem list that we had for Maple, but again, we need to change the problem list because several of the differentials there, including, as I had said before, hemangiopericytoma, mast cells do not cause lameness, and here the dog is lame. So in this case, it's more likely that we're either going to see an osteosarcoma, a chondrosarcoma, could be hemangiosarcoma, and it could be and a histiocytic sarcoma. Those would be the most likely. We can also see fibrosarcomas that go into the bone. There certainly can be cases of dogs with hemangiopericytomas or mast cell tumors that have a soft tissue mass with orthopedic issues that are causing the lameness, but it's very critical to understand that before you continue, because if the dog comes in for lameness and you find a mass and you treat that mass and the dog continues to be lame, the owners are going to be very upset with you. So here again, we scan the mass and you can see here again that we got the orange result. So in this case, again, we need to further diagnose the mass because it most likely is not benign. Again, we already discussed the differentials. And again, we did an aspirate. Here you can see that the spindle cells look a little different. They're a little more spindly, but you can still see the nucleoli. So again, what do we want to do? The main problem with all sorts of different sarcomas in the legs is local aggressiveness. And the only way that we can try to understand what the problem is by doing a CT, understanding whether surgery is possible, what surgery to recommend, and then we'll know what we're dealing with. So this is a CT of the mass. Obviously, we did a CT of the lungs too, which were okay. And here you can see that we have a lot of involvement of the bone, of the soft tissue around the bone, some bony involvement. And clearly in this case, unlike the case of Maple, there's no way that we could actually remove this and try to get good margins. In addition, because this dog is lame and it has the osteo involvement, the only surgery that we could recommend would be amputation. So as a general rule, soft tissue sarcomas are very slow growing, non-painful masses. They may have rapid cellular proliferation. They be due to intratumor hemorrhage or necrosis, that all of a sudden we can see a huge increase in the size. But usually we see them growing slowly. The symptoms are related to the site of involvement and how invasive the tumor is. There are rare reports of hypoglycemia in leiomyosarcomas, but it is very rare. The workup that we need to do for these tumors is a fine needle aspirate. Again, as we said before, they may not be cellular, but it will help us to rule out lipomas, seromas, inflammation, and abscesses. Because the last thing you want to do, and I've done it before, is not rule out a lipoma and send a dog for a CT, spending all of the owner's money, and then in the end, understand that you did a CT for lipoma that didn't require anything. So that's why we need to do these aspirates. Keep going. Because I've already said that, again, may have poor cellularity, they don't exfoliate well, but we still want to try it. And obviously, fine needle aspirate can be false negative because of areas of necrosis. The only way we're going to get a definitive diagnosis is by biopsy. And in many of these cases, the way that we're going to biopsy is actually when we do the excisional surgery and then send it for the biopsy. If we're doing an incisional biopsy, then it needs to be a place that will be excised later when we're doing the surgery. The imaging, we need to do thoracic radiographs and the area of the mass. We can use radiographs, but I actually prefer CT because usually if you're going to do CT of two areas of the mass area and of the thorax, it's pretty much the same price. Ultrasound is less used in soft tissue sarcomas, and I know that in the UK, MRI is used even more than the CT, so it's kind of what you're used to. In many cases, you just do a CBC and chemistry panel as a minimal database, and it's not necessarily going to change because of this tumor. The treatment is based on the species, the location, the stage, the histologic subtype, and the most important factors are the tumor grade and the completeness of the surgery. So surgery, many papers have looked at surgery, and there's a huge wide difference between the prognosis in different articles. So I've kind of summed it up for you here. But local recurrence after surgery has been reported to recur in 17 to 75% of the patients. So that basically means that we know nothing. Wide or radical excision of soft tissue sarcomas can provide good local control in most patients. And the median survival that has been reported is between 500 and 1800 days. So again, huge wide range between what the chances are of local recurrence and a huge range in the median survival. So back to our cases. So again, for the last case that we discussed, Bummel, who is in pain and there's bone involvement, the only thing that we can offer is amputation. And surgery, oh, sorry, this is, okay. This had a little mistake here. So this one was Maple. So Maple, based on the CT, surgery is possible. We couldn't get clean margins, but we could get a wide surgical margin, even if it's about 90% and not 120%. And the important thing when we're doing that is to know the grade. And then because the margins are not clean, we could either do electrochemotherapy to clean up the margins, radiation, or metronomic chemotherapy. Okay, so what about a case that we didn't have here? But let's say Maple's case, it was so, the mass was so extensive that there's no way that we could even remove 90% of the surgery. We couldn't even do 70% removal based on surgery. In those cases, if the dog isn't in pain, I don't actually recommend doing excisional surgery. I recommend doing an incisional biopsy so that we know the grade. Because we know that low-grade tumors, the chances of metastasis are about 10 to 20%. So we don't need to worry about leaving the tumor there. We know that if we remove it and the owners aren't going to follow up with radiation, then it's not really bothering them and it won't necessarily give us anything. So if it's a low grade, I do give the owners the chance to wait and see and perform surgery only after the mass is ulcerated and painful. In addition, if they can and if they can financially do it, it's better to do a palliative surgery and follow up with metronomic chemotherapy or radiation. But you need to discuss that in advance with the owners, because if the owners aren't going to go for the metronomic chemotherapy or the radiation, then it's probably better not to just remove the tumor and have it come back so quickly. If it's a high grade, then our recommendations change because we're worried about leaving it there. If it's a high grade tumor, the chances of local recurrence and the chances of metastasis are 50%, unlike the 10 to 20 in the low grade. And therefore, we don't want to leave that tumor there, and we're going to definitely recommend to remove it. So that's why in those specific cases, there is an indication to do the incisional biopsies. So the take-home points on soft tissue sarcomas are: diagnose every mass before you go in to remove it. Image with a CT or an MRI every single mass that is diagnosed as a soft tissue sarcoma, so you know what you're getting into and whether you can actually remove it. Consider incisional biopsies for grading, so the owners know if it's a grade 1 with less of a chance to metastasize, or a grade 3 that has a 50% chance of metastasizing, and only after the imaging, discuss the treatment options. So you can see a picture of a CT here on the right of a dog that, as you can see, if you look at the body, the changes in the body wall, you can barely see this tumor. The owners barely noticed the dog had a tumor. However, you can see that this tumor is so huge, it's completely invading between the ribs and into the thorax. So it's not like every single thing that we see out on the outside is actually what happens in the inside. And here, as you can see, we actually just saw the tip of the iceberg. So imaging is critical.
Lovely, thank you. So back to me. So hopefully you learned and have enjoyed the talk from Gillian, and hopefully the HT-Vista device can get you to the point where the owners allow you to further investigate, because I think we all appreciate that further investigation, if it's by FNA or biopsies or imaging, is key in getting those cases diagnosed and providing them with the best treatment, and offer the owners the prognosis that they are after. So just to summarize, the values of the device obviously help with improving the patient outcome and, like I said before, the compliance by the owner. A key point that we haven't mentioned yet, but this is a very much nurse-led device. So the nurses utilize this device at nurse clinics and assist the vets in managing those cases in a much more efficient way. And, you know, we've been out and about, and I'm going to show you the photo, a bit showing off, but just to show you, all the teams that are so happy that are using the HT-Vista and really kind of utilizing this device in screening those lumps and bumps in clinic to get them to the point where you can do everything that Gillian has just mentioned, which is, again, key in getting those cases treated the way they deserve. So this is us. We obviously have our mission, which is saving lives, and we invented the technology. We have the tools that are doing that, but obviously it's a joint effort. So it's a joint mission that all of us together can join forces and fight this kind of disease. We obviously need you to scan those patients and to treat them, and do the great job that you're doing in clinic. And we are happy to provide more details if anyone is interested in the device itself. And VBS, who has kindly agreed for us to do the webinar tonight, will obviously follow up and send you more details after the webinar with more information and how to get hold of us and how to get a bit more in-depth understanding of the technology and potentially how you can get it to your clinic as well. So that is us. Thank you very much. We have a few more minutes for you to ask any questions that you might want to ask. Obviously, mainly Gillian, but also myself, if you have any questions about the device itself. But Gillian and I are more than happy to answer any questions.
Yeah, thank you, Lyron and Gillian, for again an excellent lecture and there was new stats there from what I'd seen previously, which was great, and it just shows how the AA technology is beginning to really show its worth in regards of the increased data that they are able to provide, and how this piece of technology continues to progress and get more and more higher levels of accuracy, which is brilliant. The usability obviously is very easy in general practice and in referral centers. And it's just the simplicity, being able to go and do something which, when we had that poll at the beginning, times are tight. People only have so much money, and therefore being able to do a relatively cost-effective piece of diagnostics within the practice means that you can help in that decision process for people who maybe are worried about where they're spending their money, but this helps them make that decision a lot easier. Hopefully this presentation helped that and made you better understanding. And Gillian, thank you so much for those great case studies. They were really fascinating to go and see some really quite challenging oncology cases.
My pleasure.
I can see one question has come through, but please don't hold back. There will be others. Lauren, do you want to talk about this, the cost? Because I think people will be surprised.
Right. So firstly, I just want to say with regards to cost, it's very much market dependent. And I know that there are a few people here from different parts of the world. But generally speaking, because it's a new technology and because we appreciate a new technology, introducing a new technology to your clinic is sometimes is challenging. We are offering a very easy, no obligation contract, which is basically a rolling contract with 2 months notice. And the cost is basically you get the device free of charge and you pay a monthly subscription for unlimited scans and unlimited usage of the algorithm and the data and the storage in our cloud-based lab. So it really depends on where you are in the world, but it varies between £480 if you are in the UK to $650 if you are in the US. But again, more than happy to answer all those kind of more specific questions. If you want to scan the barcode, the QR code, and book a demo with us through VBS, and we provide you more specific details for where you are.
Is there another question? No, it's the same. Thank you. Any other questions, or is there aspects that you'd like to ask Gillian potentially and tap in on her experience and knowledge within the oncology market? I have a question actually. You know, what are the limits, Gillian, in regards of doing diagnostics? What are your advices for those people who may want to start up using HT-Vista and want to incorporate it within their practice, but not knowing quite which things they should look for or where they should look for them on the body system?
I think that the more you look, the more you diagnose, the more you find and the better doctor you are. I think that any mass that you find on a physical exam should be worked up, should have a scan. Yes, you do need to clip, but should be scanned. And if it's suspicious, it should be aspirated, and everything should be documented into the medical files. And then when everything is documented, then the next time they come in, you say, oh, okay, I know that this mass was 4 centimeters and it wasn't suspicious and everything was fine and it was benign, then you know that the next time you're okay. And if there was something that was, you know, so I think that it's just a matter of scanning, documenting, and then you'll be okay. Everything just needs to be organized. And as Liron said before, the critical thing is that you don't have to do this as veterinarians, that your technicians can actually do this even before the dog gets to you, and it doesn't have to waste your time. It's using valuable technician time, and then by the time they get to you, you know which ones are suspicious, which ones are not, and which ones need to be aspirated. In addition, as we hear more and more all over the world, that owners don't really like the fact that some of us really, you know, like to stick needles into their dogs as much as possible. And here, what we have is we have a screening tool that actually says to the owners, okay, we're going to check them. We're going to screen them with the HT-Vista. And only if the scan is positive, then we do need to do an aspirate. And then even owners who didn't want to do an aspirate before, the minute that there's a suspicious answer, will say, okay, now you have the rationalization to say, even though that's not something you're too thrilled about, we need to do an aspirate. So it just gives you the rationale to say that we need to do it, and causes you to have better tools and be a better veterinarian.
I think part of my question was also, I think when we first met over a year, almost a year ago, doing lower limbs was a challenge, but I know that HT-Vista have been working very hard behind the scenes to go and produce additional accessories that helps you go and do limbs, even regardless of the size of the individual animal. Is that correct? Yeah.
Yes, so there's actually coming out soon, there's going to be actually a device that is easier to hold. And there's also a better way to hold it and to get that spacer in it, so it's much easier.
Yeah, and the same goes for, I was interested in Lyron's data showing the amount of tumors that are malignant in the head area from your data. And therefore, I believe that now you're able to more accurately be able to go and monitor them around the sort of the skull area, aren't you?
But not around the eyes.
Not around the eyes, no, I appreciate
Not yet.
that. Yeah.
So there was a
Okay.
question, has this been used in human medicine? So the first study actually, before they even came to me to discuss about dogs, was in human medicine and with oral tumors, and it was actually very successful. And now there are there's a study being done in human medicine, actually intra-op, to try to understand the margins of different tumors when they're doing surgery. But things in people just take a lot more time than dogs. So that's this first study should be published soon, but the second study will take a long time.
And it's very poignant as well, because Shani, the founder of the whole of the company, developed this product because of the cancer that her father had, isn't that correct?
Yes.
And that was very much the driving force behind it. So I can imagine human products will be coming.
Yeah, I can answer the question from Michael. So in terms of size limitation, the smallest mass that can be scanned is 5 millimeters. So below 5 millimeters, it's a bit tricky and challenging to scan those very kind of little masses below 5 millimeters. In terms of depth, the heat wave penetrates the tissue about 5 millimeters into the tissue. However, it's down to the tissue's texture and consistency, how the tissue and how the cells transform, and how kind of the heat is being conducted and diffused within the tissue and then back to the senses. And that's, I guess, part of the technology, which we measure the heat diffusion within the tissue. So this is roughly the size limitations of the mass. I mean, big, huge masses, obviously. I mean, to be honest, I mean, Gillian would probably say that if it's a huge mass, right, it probably needs to be removed. But if it's a big mass, as long as you scan part of the mass alongside the healthy skin next to it, then the device, the algorithm, has enough reference to use to analyze and tell us what's happening within the mass area.
I'm sorry, before that, Lyron, you answered a question in regards of clipping, and yet, yes, you do need to clip the coat in order to get an accurate picture in regards to the heat diffusion. So I know you typed that for that individual, but just for the general population. Yeah.
Yes, absolutely.
There's a question for you about Australia, and I think I've been helping you with someone in Australia. So
good timing, right, Stephen?
Yep.
Yeah, I've just spoken to a distributor, basically Stephen's colleague in Australia, and we are hoping that it will transform to a collaboration. So hopefully we'll get to Australia soon. We do have about 7 or 8 clinics in Australia already using the device, which is quite nice and interesting. We are hoping, obviously, to grow in this market as well.
Yeah. Any other questions there?
It's quite interesting because obviously Australia has a very high awareness, right, of skin cancer in humans. So so dogs are benefiting, I guess, from this awareness, and Australia is very good in skin awareness. So I'm hoping that will be successful as well.
Quick question: any risks? Is any risks in regards to the skin being burned, or is there risks in regards to doing it over mast cell tumors?
No. So overall, we have scanned hundreds of thousands of masses to date, We did have a couple of masses that developed a very kind of small local reaction to potentially the scan. However, those two masses were also sampled, and they were mast cell tumors. So we don't know if the reaction, the local reaction, is due to the finite aspiration itself, or the scanner. But again, 2 out of hundreds of thousands. I mean, no, I would say no. The degrees in terms of the heating of the tissue, the tissue is being heated by a very safe blue LED light, between 6 to 7 degrees Celsius. So it's very comfortable, pain-free, and they hardly feel anything. It's quite kind of nice and comfortable, I would say.
Gillian, question to you. Is it possible, sometimes you get some very subtle ulcerative lesions, which may actually be a cancer, but you're not sure about it. Would you do it over an ulcerative lesion, or would you not do it over something where there's skin damage?
At this point, it is not indicated for ulcerated lesions.
Okay, so it's better to take a skin scrape or a smear on that and work on that basis. Yeah. Any other questions there? Christine's, obviously we've answered that. And what other I mean, I know that you're constantly going and improving things, and there is a constant appetite to improve stuff. Obviously, the AI is a great tool in regards of being able to perfect and improve the level of predictive values that you're looking for. But is there any other things that you might be able to excite people about in the future? Not that the technology doesn't need it, but
so the main projects that we want to work on now, with several different oncologists in Europe, is actually looking at grading of tumors. So we discussed about the fact that soft tissue sarcoma, it's so critical to understand the grade, whether it's a grade 1 or a grade 3, because that actually tells us what the chances are that this tumor will metastasize. So we're going to try to see whether, based on the scan, we can know what grade of the tumor is, and then it would save us those incisional biopsies. The same thing for mast cell tumors, where everybody knows that grade in mast cell tumor is critical to understand for the prognosis and even for the surgery. So we're looking at grading of mast cell tumors and soft tissue sarcomas. Those are studies that we're going to launch in the next month or two. And we're also going to start looking at mammary tumors in dogs.
Yeah, no, mammary tumors I'm very excited about. It's obviously a major part of veterinary practice, and if we could do them and prove to people why they need to be biopsied earlier, I think you could do a lot for improving the longevity of some of the dogs' lives.
And just to add to your question and to answer the question from Christina, so yes, we keep updating the technology, if it's the software itself, if it's the algorithm that keeps being kind of trained and improving its performance, and all of this is being updated and uploaded to the devices worldwide automatically. It goes out. It's with a click of a button. You will get your software, and at the same time the classifier that's being used updated, and then start using the new updated algorithm or software. So everything is happening due to other technologies happening very quickly in practice.
Just to mention, if you do a QR code of that demo booking on the screen, we do have a promotional offer at the moment, so it's well worth doing that. There's no obligation in regards of us sorting out a demo, and we would work closely with Lyron and his team, and our team would be out there in the field helping to go and support you. But if you want to make use of that promotional deal, it's well worth scanning. There's no, as I said, obligation to proceed, but it would give you a much better idea to help the rest of your practice understand. And we will have a recording of this, so if there are people who have not attended tonight, which is there are a significant number who signed up who haven't attended, then we'll make sure that they get the recording so that they can listen in their own leisure. But I appreciate all of you for turning up tonight. I think there's one more question there, but no, it disappeared.
It was
Uh,
just
is
where's
that
the
about-
QR? The QR is on the screen in front of you.
Yeah, it is right in front of you. Yeah. Okay, I don't know whether there's any concluding things that you and Gillian would like to say.
Thank you
I
very
think
much
just
for
to
coming.
thank you. Yeah, just to thank you for hosting us today, tonight even, or today, depending where you are. And hopefully you found the cases interesting, the technology interesting, and yeah, we're looking forward to speaking to everyone if they're interested in finding out more. So thank you very much.
Thank you. And thank you, Gillian, and keep up the
Thank
good work
you.
and keep pushing the boundaries.
Thank you so much. Good night.
All right. Thanks, Lyron. Nice seeing
Thank
you.
you.
Bye.